Hi, my name is Tom Nelson. I'm a professor of radiology at the University of California in San Diego. And today I'd like to discuss some things to check before you scan a child with CT. We have several different goals to accomplish during this presentation. First, a brief review of CT scanning and the radiation sensitivity of children, some radiation dose concepts related to CT scanning, some of the key factors influencing radiation dose and study quality, and optimization of scan parameters, resulting in reductions of dose and improved scanning protocols. And finally, we'd like to provide some practical tips for reducing radiation doses to children. But it's important to appreciate that children are not small adults. They have quite different imaging needs, their cells are dividing in a different way and are more radiation sensitive, and their body proportions are different. Thus, we must always adjust and optimize to the individual in order to maximize information and minimize radiation dose. New CT technology has facilitated more rapid and sophisticated scanning. However, the potential exists for overexposure with such capability. The number of CT examinations has doubled over the last 5 years, with over 60 million examinations per year. Of those, 4 to 7 million examinations are performed in children. As we can see in the slide on the lower left, in this pie chart, approximately half the radiation a member of the general public receives is due to medical radiation exposure, and of that, half, or a total of 24%, is from CT scanning. Thus, we have a lot of incentive to be very careful and to optimize our CT scanning protocols. Now, the radiation dose from a single CT scan is relatively low, but children absorb a higher dose than when adult-sized imaging techniques are used. Children's cells are more susceptible to the effects of a given radiation dose, and thus there's a slight increased risk for developing cancer from stochastic or non-deterministic effects that are related to the induction of carcinogenesis. Additionally, there may be changes to the child's genes over the course of their lifetime, and these genetic effects can be passed on to their offspring. Finally, deterministic effects will occur at given dose levels, and these are among the most readily visible that we identify. Radiation effects on children's cells are cumulative, and the risk increases with each exposure. Thus, some studies suggest that pediatric CT scan doses are higher than necessary, and we need to be particularly vigilant in small children. Defining the risk of a CT dose is complex for several reasons. First, risk assessment involves populations of patients, and there is a risk versus benefit assessment for each CT study. And additionally, there is an intrinsic risk for developing that disease independent of radiation. As we can see in the lower graph, the risk of cancer induction for individuals exposed to 100 milligray, which is a relatively high dose, decrease dramatically with age and are particularly important in younger individuals and women below the age of 20. So we have to be very careful with our pediatric population. Radiation dose is measured in CT in units of absorbed dose, which is the amount of energy absorbed per unit mass. We use a unit of 1 gray, which is equivalent to 1 joule per kilogram. We also report an effective dose, which is reported in units of sievert, and that is the estimated critical organ absorbed dose multiplied by an organ-specific weighting factor. As can be seen in the table below, CT contributes the greatest per capita dose of all the radiological studies, and once again, its use is growing, so we need to be very careful in our protocol development. We measure CT radiation dose using a parameter called the Volume Computed Tomography Dose Index, or CTDI Ball. It's reported in milligray, and it's a parameter measured in an acrylic phantom of either 16 or 32 centimeters diameter under standard conditions and reported in the dose measurement. The console CTD is based on manufacturer factory measurements, and they are verified at each site by a medical physicist. It's a very useful parameter to track dose across patients, protocols, and scanners. In addition, the ACR Dose Index Registry allows CTDI Ball comparison across institutions. However, it's important to realize that CTDI provides an estimate of patient dose, and the accuracy depends on the relative size of the patient to phantom. So in this example, we show 3 different phantom sizes from 32 to 16 to 10 centimeters in diameter. We measured the CTDI Ball for each of them, and you can see that it increases as the phantom gets smaller for the same technical parameters. The red box on the bottom shows the CTDI Ball for a 16 centimeter phantom measurement, where there's fairly good agreement with the 16 centimeter phantom. Similarly, the brown box shows for a 32 centimeter phantom, which has very good agreement with the measured values. However, the 10 centimeter phantom is significantly different with both of those, pointing out the necessity of tailoring the CTDI measurements to the patient size and anatomy. We also measure the dose length product, which is calculated by the scanner. This is the product of the length of the radiated scan volume and the average CTDI ball over that distance. It has units of milligray centimeter. As can be seen in the figure at the bottom, the CTDI ball varies with the anatomy being scanned, and the DLP is an integration of those values throughout the anatomy. The effective dose in CT is the dose length product multiplied by a conversion factor that once again takes into account organ size and its radiosensitivity. As can be appreciated in the table, you can see that the conversion factor depends on the region of the body being scanned and the age of the individual being scanned. Additionally, various regulatory bodies, professional organizations, and countries have defined diagnostic reference levels for CT in adults and in children. This table shows them from around the world. In the United States, the American College of Radiology has defined a diagnostic reference level for head CT and abdominal CT. These values are monitored as part of the ACR accreditation process for CT. New technology has facilitated more rapid scanning. As we can see in this brief video, from an inside of a 64-slice CT scanner, there's a great deal of advanced technology present, and the ability to rotate extremely rapidly gives rise to potential for very, very fast scanning as well as more sophisticated diagnostic studies. There are several parameters, though, that affect the CT dose from these scanners: the beam energy, the Xrayfluence, the detector configuration, the pitch, the exposure length, and the number of phases of imaging over the same anatomy. The beam energy, or tube potential, is the amount of energy the X-ray photons will have, and it's adjusted at the beginning of the protocol. It's approximately proportional to the square of the percentage change in tube potential when we change between two different KVPs. Decreasing the KVP reduces the patient dose and improves tissue contrast. This is very important in children, and as can be seen in the image at the bottom, by reducing the KVP from 120 to 100, we can improve the soft tissue contrast and also reduce the dose by about 20%. The Xrayfluence, or tube current, determines the number of electrons accelerated across the X-ray tube. This also determines the number of X-rays produced. It's given in unit of milliamperes. The dose is directly proportional to the tube current, for all other parameters being fixed. The graph at the bottom shows the relative beam current across a range of body sizes for both head and abdominal studies. Since the MAS is also a proxy for the dose, we can see that by taking into account the patient body size, we can achieve significant reductions in the dose by reducing the MAS. Modern CT scanners use multiple detector systems that became available in the mid-90s. These scanners significantly reduce scan times and allow equal resolution in X, Y, and Z directions. The detector configuration determines the beam width, or aperture or collimation, and it's based on the number of data channels times the detector width for each data channel. The graph at the bottom of the slide shows that as we increase the aperture, the relative CTDI decreases, and as a result, we can achieve significant dose savings by using the widest possible beam aperture. The table moves through the gantry either in a continuous acquisition mode, such as for helical scanning, called table feed, or in a step and shoot approach for axial acquisition. The pitch is the ratio of the table feed per gantry rotation divided by the beam width. It's inversely proportional to the pitch. So if we reduce the pitch, we have more significant beam overlap, and the dose will go up compared to a pitch of 1. Conversely, if we have a pitch greater than 1, the dose will decrease, but there will be gaps in the scan that may miss important anatomy. The net result is that the effective tube current time product is the MAS divided by the pitch. It's reported in milliamperes per second. The dose is directly proportional to the effective tube current time product. Lowering the MAS is the most direct way to reduce the radiation dose. However, lowering the MAS too much can produce a lower quality image, resulting in a misdiagnosis or requiring a repeated scan. The exposure length is the length of patient anatomy in the Z direction exposed to the X-ray beam. It should always be optimized to the organ of interest. In addition, the number of phases refers to the number of times the same patient anatomy is irradiated. As we can see in this lower picture, from a CT perfusion of a head, there are multiple acquisitions of the same anatomy. This can be useful to produce intensity time distributions for a contrast material. However, that portion of the anatomy continuously radiated will receive a significantly higher dose, and protocol optimization is essential. There are several enhanced dose reduction strategies that we can use, however. The first is using the automatic exposure control capabilities of the scanner. This can happen through automatic tube current modulation or tube potential selection based on the localizer images. However, with either of these approaches, it's very important to center the patient in the gantry for the AAC system to work properly. It should be noted that the CTDI Ball or dose will go up for larger patients and decrease for smaller patients. In the image on the lower left, we see the tube current modulation longitudinally through the patient through the chest and abdomen. If we also look at the center image where we see angular modulation based on the effective thickness of the patient, this varies through the rotation. Combining these two is shown in the lower right-hand image, where we see the variation in tube current as a function of rotation and also longitudinal position. As mentioned, it's very important to position the patient at the center of rotation, as is shown in the upper right-hand image. The lower left-hand image shows the patient below the center of rotation, in which case the localizer image will show a smaller patient than is actually present. Conversely, if the patient is above the center of rotation, a larger patient than is present will be used for the calculation of the AEC parameters. So it's essential to center the patient. In addition, we can use ECG-based tube current modulation for cardiac studies, which will turn the radiation on and off depending on the time of the cardiac cycle desired to be imaged. And finally, we can also use organ-based tube current modulation, where we decrease the tube current over radiation-sensitive areas such as the breast and increase it in other areas that are less radiation-sensitive, as shown in the lower image. The green arrow pointing to the reduction in dose to the breast area, but conversely the posterior part of the body receiving a higher dose. An additional approach that's becoming more common is to use iterative reconstruction algorithms. In this approach, the algorithm uses information acquired during the scan and repeated construction steps to produce an image with less noise or better image quality. Iterative reconstruction improves image quality compared to filtered back projection. It allows acquisition and reconstruction of diagnostic quality images at far lower radiation doses. The lower left image shows a standard dose of 160 mass for a renal perfusion study. The center image shows the same study but with 10% of that dose, or 16 mass. That's very noisy and difficult to interpret. The lower right image shows the lower dose after iterative reconstruction, which has now produced a diagnostic quality image. Some of the ways that we can reduce radiation exposure in the pediatric patient is to use a team approach with the radiologist, the physicist, and the technologist. The radiologist is responsible to ensure that every imaging study in pediatric patients is thoughtful, appropriate, and indicated for every child. The radiologic technologist is responsible to ensure that protocols are adjusted to use child-size parameters and verify proper scan technique factors are set for each pediatric scan. The medical physicist is responsible for improving image quality, providing guidance on appropriate pediatric techniques, and ensuring that young patients are imaged using radiation as low as reasonably achievable, or ALARA. In addition, the Image Gently website provides educational resources on what can be done to improve radiation protection in children. So some of the practical issues available for limiting patient exposure is to use in-plane shielding. Now this is somewhat controversial, but it can reduce the dose to sensitive organs, but the shielding can only be applied after the scout views are acquired, and it may increase dose if not used properly. The image on the right shows the orange line, which is a fixed MAS setting for the scan. The green line is the optimized dose modulation as a function of longitudinal position, but the purple line shows what happens if the shield is in place during the localizer images, and you can see there's a significantly higher dose associated with that. Also important in children is motion artifact reduction. We needed to immobilize infants and children to reduce motion and avoid repeat scans. To do this, we can use faster scan acquisition parameters and also immobilization devices. Another important issue is helical overranging. Pediatric scan ranges are shorter than for adults. The dose from helical overranging is far greater for children than for adults, and thus it's better to perform a single helical scan acquisition rather than multiple segments when clinically acceptable. The use of narrower Z collimation or aperture is important for short helical acquisitions. As we can see in the lower image, the scan range has significant excess overscan from helical acquisitions, and this is minimized as we have a longer scan range. If we have a short scan range, then if we use a smaller aperture shown in the lower right, we can also reduce the overscan excess radiation dose. So for some practical tips on how to reduce radiation dose and improve our protocols, we need to remember that new scanner technology offers new opportunities to reduce radiation dose through automated tube current modulation, automated tube potential selection, and iterative reconstruction. However, new scan technology also offers new challenges to reduce radiation dose by more complex exams inviting overuse and dynamic studies with repeated scanning producing very high doses in selected areas. Some practical tips to consider: review the number of previous radiation studies that have been performed to ensure that the study requested is essential and that cumulative study doses are not getting excessively high. Assess the reasons for the current CT scan. Perform only necessary CT scans, and importantly, consider alternative imaging modalities such as MRI or ultrasound whenever possible. Remember to create a child-friendly environment for the patient. Scan only the organ or anatomical region indicated. Decrease the KV on smaller-sized patients. Use MA modulation. Use the appropriate field of view. Use iterative methods to further reduce dose in patients. And eliminate multi-phase studies whenever possible. Make sure to reduce the MAS in repeat studies also if that is possible, such as shown in the images on the lower right, where verification of a shunt placement is required as a follow-up study, and a much lower MAS is possible without compromising diagnostic information. So, in conclusion, radiologists can successfully implement a system of continuous process improvement for CT radiation dose levels by determining baseline dose levels for various CT study types at their institutions, setting goals for dose reduction, modifying CT protocols to take use of the capabilities of the scanner and achieve those goals, and implementing changes incrementally and iteratively to continue to minimize adverse effects and optimize scanning protocols for children. There are a number of useful websites available. Image Gently, the American College of Radiology, and the Radiologic Society of North America have very valuable information. Thank you very much.